Okay, osteoarthritis is the most common joint disorder in America, and it really increases with age. You often see it more in females than males, and you often see patients with pain in their knee, their hip, and their hands. Step 2 really likes modifiable risk factors, so obesity or excessive joint loading or even overuse of your joints are the biggest modifiable risk factors. The non-modifiable risk factors are ages over 55 years old or a history of trauma or injury to the joint. For those studying for step 1, the pathophysiology is because of mechanical stress on joints. Eventually, the cartilage on the joint loses elasticity and it becomes very friable. When something becomes friable, it becomes subject to inflammation. Eventually, the space between your joints starts to narrow, and then you have sclerosis of the subchondral bone. Very high yield. The clinical features is pain during or after you exert, so usually at the end of the day, and it's relieved at rest. This is the one where morning joint stiffness usually lasts less than 30 minutes. These patients also have crepitus, or they hear popping sensations when they're moving their joints. Very silly, but I remember osteoarthritis as the joint stiffness in the morning that lasts less than 30 minutes because when I wake up in the morning, I stretch my arms and I go, oh, this morning stretch doesn't last very long, and that's how I remember it, osteoarthritis. Lastly, but very, very ideal, the distal interphalangeal joints can have nodular thickening, and so can the proximal interphalangeal joints. For the DIPs, these are Hebertine nodules, and for the PIPs, these are the Bouchard nodules. And I remember this because it's an alphabetical order from proximal to distal. B is proximal, H is distal, Bouchard and Hebertine. Osteoarthritis is a clinical diagnosis, and you should approach this with non-pharmacological and pharmacological therapy. Non-pharmacological treatment would be exercise or weight loss, and you can also give for pharmacological treatment NSAIDs, acetaminophen, or even intra-articular glucocorticoid injections. Remember, if you see NSAIDs and intra-articular glucocorticoid injections in the stem, make sure you look to see if the patient has any renal problems. You cannot give these patients NSAIDs. Lastly, surgical management is given if all the conservative measures fail.